Kidney disease. Improving global outcomes, KIDOGI, was originally established in 2003 by the National Kidney Foundation, a U.S. foundation experienced in developing and implementing guidelines. In 2013, KIDOGI became an independently incorporated non-profit foundation and is governed by an international volunteer executive committee. The KIDOGI Global Network promotes awareness, dissemination, adoption, and clinical integration of KIDOGI clinical practice guidelines globally. The global network is composed of volunteers from around the world who work to implement KIDOGI guidelines in their respective countries or regions. Acute kidney injury, AKI, is where your kidneys suddenly stop working properly. This injury to the kidney develops with hours or days. It can range from minor loss of kidney function to complete kidney failure. AKI normally happens as a complication of another serious illness. It's not the result of a physical blow to the kidneys, as the name might suggest. It's very important that AKI is detected early and treated quickly. If the kidneys shut down completely, the patient will require dialysis. Any issue that decreases blood flow to the kidneys can be a cause of AKI. With AKI, it is possible for the kidneys to regain function. Chronic kidney disease, or CKD, means the kidneys are damaged and can't filter blood the way they should. This disease is called chronic because the damage to the kidneys happens slowly over a long period of time. This damage can cause wastes to build up in the body. CKD can also cause other major health problems. Further damage to the kidneys can be prevented, but is most likely not reversible. Although chronic kidney disease and acute kidney injury are two separate disease processes, the presence of one can be related to the other. Chronic kidney disease is a major risk factor for developing an acute kidney injury, which can lead to chronic and end kidney disease. Patients with existing chronic disease have a more difficult time recovering after an acute kidney injury. Acute kidney injury, AKI, the new term. Acute renal failure, ARF, commonly caused by ischemia and nephrotoxins. Remember, AKI happens abruptly and may be reversible. The prognosis is usually based on cause and comorbidities. It can take up to a year for patients to recover to their baseline kidney function. AKI is loosely defined based on increased serum creatinine over 2 to 7 days or oliguria. Diagnosis is much more complicated and specific. However, you don't need to know the details at this point. Symptoms of AKI can include decreased urine output, although occasionally urine output remains normal, fluid retention, causing swelling in legs, ankles, or feet, shortness of breath, fatigue, confusion, nausea, weakness, irregular heartbeat, chest pain or pressure, seizures, or coma in severe cases. AKI is broken into three types of renal failure. These are pre-renal, post-renal, and intrinsic. In pre-renal, there is a decrease in renal perfusion, often caused by hypovolemia, which lead to a decrease in GFR, and this is often reversible. With this type, there is nothing wrong with the kidney itself before injury. Intrarenal is also called intrinsic kidney damage. Most often, the kidney is damaged by some outside factor. The most common cause is acute tubular necrosis, ATN, due to an ischemic or nephrotoxic injury. Postrenal occurs because of an extrinsic or intrinsic obstruction of the urinary collection system. Examples are kidney stone, stricture in the ureter, or bladder cancer. ATN is damage to the tubule cells of the kidneys, and this can lead to AKI. ATN can be caused by ischemia or nephrotoxins. Ischemia is the most common cause. Anything that would cause a drastic drop in blood pressure and/or blood volume could cause ATN. There is also a risk of ATN from nephrotoxicity caused by certain medications, contrast dye, some chemotherapy drugs, and overdoses of certain substances. NAC and acetylcysteine. Prior to receiving IV contrast, nurses, doctors should assess a patient's renal function to prevent contrast-induced AKI. There are both pharmacological and non-pharmacological ways to reduce the risk of someone developing this type of AKI. Certain medications such as N-acetylcysteine and increasing volume to flush out the contrast post-procedure are examples of pharmacological prevention measures. Non-pharmacological interventions include decreasing the dose of contrast used as well as the type. Refer to page 379 in your text for more information. However, the following clinical findings can be indicators associated with AKI. Anemia. What do you see? Fatigue, pallor, dizziness, confusion, lethargy, tachycardia, tachypnea, hypotension. Fluid volume excess. What do you see clinically? Dependent pitting edema, respiratory crackles, dyspnea, pulmonary edema, weight gain, tachycardia, JVD. Hyperkalemia. What would you expect to see? Ventricular arrhythmias, tall peak T waves, widened QRS, cardiac arrest, smooth muscle hyperactivity, nausea and vomiting, abdominal pain, diarrhea, muscle weakness, flaccid paralysis. Treatments for each are listed on slide. Management of the patient with AKI includes monitoring the patient closely, including hemodynamic status, urine output, weight, labs, neurostatus, any signs of infection, and fluid overload. Patients will need to stick to a renal diet that is low to moderate in protein and low in phosphorus. Phosphorus is commonly found in protein and is damaging to the kidney. High carbs and restrictions of potassium and sodium are based on patients' electrolytes. Medication doses should be adjusted based on a patient's renal function. A patient may require dialysis, either intermittent or continuous, with continuous renal replacement therapy. CRRT may be used in ARF or ARF to treat fluid volume overload or rapidly developing azotemia and metabolic acidosis. It minimizes fluctuations in fluid status that may be too significant for the critically ill patient. This is a list of foods that may be restricted with patients with AKI and CKD. It is recommended that patients be evaluated for risk of AKI according to their susceptibilities and exposures. The risk of AKI is reduced in these identified patients when monitoring is implemented based on the patient's individualized risk and clinical course. The fact that some 30% of patients who recover from AKI remain at increased risk of CKD, cardiovascular disease, and death, it is important to identify such patients in the hopes of providing them with timely preventive measures. Chronic kidney disease is a slow, progressive, and irreversible loss in kidney function. It is defined as a GFR of less than 60. It can affect all body systems and often causes hypervolemia. It occurs in stages 1 to 5, and if progression to ESRD, the patient will require dialysis or kidney transplant. In the Healthy People 2020 objectives, there were goals for CKD, and progress has been made in the areas of focus. Goals included a reduction in the disease burden, people with CD to live longer with an improved quality of life, and eliminate disparities among patients. The cost of treating CKD and ESRD is important to note. Almost 25% of the Medicare budget goes to treating this disease process. Here are some statistics from the 2018 U.S. Renal Data Systems Annual Report. The top two major causes of CKD include diabetes and hypertension. The most common symptoms of CKD include blood in the urine, high blood pressure, and fatigue. There are many other common signs and symptoms listed. Most will be a result of excess fluid, abnormal electrolytes, and retention of wastes. When patients have progressed to stage 3 or 4 CKD, evaluation and treatment of secondary hyperparathyroidism, low calcium, and increased serum phosphorus levels become important. Treatment of elevated phosphorus includes implementing a low phosphate diet. See Table 6. The use of phosphate binders and vitamin D supplementation are often needed. Hyperkalemia is a common problem in those with renal failure. It typically occurs as CKD advances into stage 4 and 5. It is more common in those with diabetes. Patients should be taught which foods increase the risk for elevated potassium levels. See Table 7. Many fruits and vegetables are high in potassium. These foods should not be avoided completely, but patients should be given guidelines for how much is safe to eat. Many medications have potential to increase serum potassium levels in those with CKD, including your ACE inhibitors, ARBs, aldosterone antagonist, spironolactone, and non-steroidal anti-inflammatories such as ibuprofen. End-stage renal disease results when there is little or no kidney function stats above or from 2013. Why is ESRD so prevalent in the southern state? Almost half of the individuals with CKD also have diabetes and/or self-reported cardiovascular disease, CVD. 468,000 individuals are on dialysis, and roughly 193,000 live with a functioning kidney transplant. Kidney disease often has no symptoms in its early stages and can go undetected until it is very advanced. This slide shows the manifestations of CRF. The first system is body fluids. The patient may experience polyuria caused by metabolic acidosis caused by a decrease in hydrogen excretion and abnormal levels of sodium, potassium, calcium, and phosphorus. These may be caused from loss of tubule function. If potassium levels is high, there are treatments that can be used to lower it, such as electrolyte binding and electrolyte excreting medication, Kayexalate, 50% dextrose, and insulin IV, low potassium diet, calcium gluconate, sodium bicarb, loop diuretics, and even aerosolized albuterol. Phosphorus is needed for maintaining the body's acid-base balance. Phosphorus is excreted by the kidneys, so with the kidney damage, phosphorus is likely to increase. A level greater than 4.4 is considered hyperphosphatemia and can cause tetany. Treatment options are the administration of phosphate binders, TUMS, sevelamer, which is Renal gel with meals, calcium acetate or Foslo, because of the inverse relationship between calcium and phosphorus. Stool softeners are important because binders are constipating. Changes with the hematological system can occur, resulting in anemia and excess bleeding due to impaired erythropoietin production. It is important to monitor the hematocrit and hemoglobin. Treatment can include epoetin alpha, epogen or procrit, iron, blood transfusions, but only when necessary. They may decrease the stimulus to produce epoetin and cause the body to produce antibodies, which make transplant difficult, and also folic acid. Sometimes iron is given IV because it is not absorbed well when taken orally. When administering iron, it is important to place the patient on a stool softener to avoid constipation. The cardiovascular system may result in hypertension or edema. This is caused from activation of the RASS system. Nausea and/or anorexia may occur because of issues with the GI tract. Neurologically, the patient experiences encephalopathy due to the accumulation of waste products, and they may experience muscle and bone weakness known as renal osteodystrophy from the loss of calcium and minerals. Uremic syndrome occurs when there is an accumulation of waste products in the blood. These waste products form as tiny yellow-white crystals on the skin, resulting in a frosted appearance as sweat evaporates. So healthy kidney tips: lose weight if you are overweight, get active, physical activity helps control blood sugar, quit smoking, getting a checkup, make sure to get your kidneys checked too, take medications as directed, keep your blood pressure below 120/80, or ask your doctor what the best blood pressure target is for you. If you have diabetes, stay in your target blood sugar range as much as possible. Stay in your target cholesterol range. Eat foods lower in salt. Eat more fruits and vegetables. These are blood pressure parameters and stages of hypertension per the American Heart Association. Sean Elliott played in the NBA from 1989 to 2001. In 1999, the Spurs defeated the New York Knicks in 5 games and claimed their first NBA championship. But throughout the celebration of a remarkable playoff run, Sean Elliott needed a miracle of his own just to stay on the court. He was diagnosed with focal glomerulosclerosis, a disease that prevents kidneys from properly filtering waste from blood. Elliott's condition had grown to the point where it was affecting both of his kidneys. With a month left in the regular season, doctors told him that he would need a transplant. Elliott kept that knowledge a secret until July 22, 1999, when he announced to the media that doctors were actively looking for a donor.